So hello everyone, my name is Lauren Schnack. I am Dr. Rodriguez's fellow at Amita Health St. Joseph Hospital, Chicago for the Complex Deformity Correction and Limb Reconstruction Fellowship. We are here doing a podcast today with our guest, Dr. Tudor Tien. Dr. Tien is a practicing foot and ankle surgeon in Jackson, Michigan. And more about Dr. Tien, he has hospital affiliations at Henry Ford Allegiance Health, Genesis Regional Medical Center, which is also in Grand Blanc, Michigan. He is clinical assistant professor at Michigan State University, clinical assistant professor for quite a few years now. He is vice chair at Henry Ford Allegiance Health, IRB. He received his Bachelor of Arts degree in chemistry from Columbia College and went to the University of Michigan Medical School for his MD degree. He did a general surgery internship at the National Naval Medical Center in Bethesda, Maryland. He also did a orthopedic surgery residency at the National Naval Medical Center in Bethesda, Maryland, and a foot and ankle fellowship at the Union Memorial Hospital in Baltimore, Maryland. He has military service also in Okinawa, Japan, and he is also a general medical officer. He's also staff orthopedic surgeon in Italy as well. He is board certified by the American Board of Orthopedic Surgery. He was awarded the Navy Achievement Medal, and he has associations with the American Academy of Orthopedic Surgeons, American Orthopedic Foot and Ankle Society, and the State of Michigan Medical Society. He is also a published author and an academic lecturer as well. We are also here with Dr. Edgardo Rodriguez. He is part of the adult and pediatric ill-Lazarov limb deformity correction, which is his special interest. He also has a special interest in peripheral nerve and reconstruction microsurgery. He is a board member and fellow of the Association of Extremity Nerve Surgeons and the fellowship director for the Complex Deformity Correction and Limb Reconstruction Fellowship, and is also founder and chairman of the Chicago Lower Extremity Symposium and founder of the American Orthoplastic and Microsurgery Society. We also have Deval Patel here, who is the incoming fellow to North Jersey Reconstructive Foot and Ankle Fellowship under Dr. Subik. And we have Julie Morris from Preventagen, who is Vice President of Clinical Research and Product Development for Prevent Plus. So welcome, everybody. Thank you for being here today. And let's jump right in. Thank you so much for being here, Dr. Tien, and for being our guest on our podcast for IOMS. And here we are going to discuss external fixation and management. So, Dr. Tien, when would you say, let's start off with the basics, when is X-Fix used? When do you prefer to use external fixation?
Well, I think there are two basic categories. One is trauma and the other is reconstruction. I like external fixation for both of those applications. In acute settings in trauma, an external fixator can be very helpful in managing soft tissues while you wait to do definitive fixation, whether that's with an external fixator or with internal fixation. In reconstructive situations, using a external fixator can be extremely helpful for a number of clinical things, fusions, bone osteogenesis. So that's kind of the broad categories.
Great. And then what are the challenges that you're seeing with external fixation?
Challenges. I would say patient acceptance. That's a significant component to using external fixators. They require a lot more management on the part of your patient, so they have to be agreeable to using an external fixator. So education's important with regards to that. Technical challenges with external fixations are numerous. I think good frame constructs and being able to provide long-term fixation sometimes needed for 3 months or 6 months um, is a component. Also, I think in terms of management in the office, external fixators require a lot more participation by office staff. And so I think using external fixators in your practice does require you to adjust. It's not a 15-minute patient follow-up appointment when somebody comes in with an external fixator. Having the industry assist with managing the external fixators, I think, is very important. So generally, when I use external fixators, I like to be able to have the companies which provide the external fixators also provide a great deal of care, whether it's if you're using some type of a hexapod device where you need to do um, modifications to the frame and you need to be able to uh, 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 adjust it in the office, having those people involved and helping you do that frees up your own office staff, which practically is indispensable. So,
And Dr. Rodriguez, when do you use external fixator, and what are the challenges uh, that you have seen or experienced with the use of external fixator?
Well, I agree completely with Tudor on the sense of the when do you use it on the trauma and the reconstruction, and I agree also completely that one of the biggest challenge, not the most, is just having the patient acceptance to the product, to the device that we utilize, and the and how much delay it creates in your clinic. Um, and these two things perhaps are the two main factors why so many surgeons in circumstances that maybe external fixation may have a bit of an advantage may go a different way of fixation um, to try to avoid the other factors such as delayed clinic and patients' adherence to the protocol. It's extremely painful to have a patient that while you're seeing them, they're basically asking you constantly, perhaps, when they're going to have the fixator device off. And it's just additional stress that is in the entire treatment scenario, let's put it that way, in which it's a patient that constantly, that psychologically they could be affected. The family is a lot of work for the family to also maintain and help them in the process. But inevitably, in the acute setting for the patients that they have open trauma or the patient that the soft tissue envelope angiosomes are completely destroyed, there's the possibly is the only single best way to treat them. So sometimes we cannot escape the use of pin to bar in the acute setting or circular fixator in the post-traumatic or the complex reconstruction of the limb. And then I think that that's really how I summarize, when to use it and the challenges. A few things that I can add before we move to the next topic will be the fact of the gradual correction. The process of gradual correction of limb lengthening is a painful process. In internal fixation of an ankle fracture pylon, usually the patient start getting better with less symptoms while you stabilize the osseous segment. When you use circular fixators for lengthening procedure, the distraction time is a painful time, and it's when you have to start dealing with the distraction rate. Maybe instead of uh, uh, 2 times a day, maybe 3 times, just to split the distraction so it's less painful. Maybe then just add some additional pain medication during that time. So there is an evolving, constant treatment. It's not static when you're using circular fixator, and it requires a little bit more you to be more engaged. And what Tudor does, that trying to get the companies involved when it comes to the use of Hexapod, I think is very valuable. Thank you.
Great. So that's a good segue into another question. So Dr. Tien, do you think that there is a place for like delta frames and things, or do you prefer the circular fixators and such, like the Ilizarov typical construct?
That's a great question. I think the two general classes of external fixators are a monopolar Hoffman type external fixator with pin to bar, and then the other broad category is an Ilizarov thin wire circular external fixator. And in the United States, we use a lot of hybrid external fixators, which borrow from the half pin use using a circular fixator for the advantages of that. So with the half pins, you have a certain amount of increased rigidity. So you can use that with a ring, half pin, and wires to avoid any translation of the bone segment, especially if the wires are crossing at angles less than 60 degrees. They have a tendency more to shift. So if you add a half pin, that allows you to have better stability of that segment. And so in my practice, I find that because I'm not on call all the time, but I am responsible for a lot of the foot and ankle surgeries at my institution. I have partners who are going to put on external fixators, so then I'm going to see the patient afterwards. So most orthopedic surgeons in their training learn how to do delta frames, which typically a couple of half pins in the tibia and a transfixion pin in the calcaneus, maybe an additional smaller pin in one of the metatarsals to prevent equinus contracture. And that device is used to stabilize somebody with a pilon fracture, and then they can be managed subsequently after the soft tissue swelling has gone down. So with that type of situation, although I like circular fixators and I'm interested in transitioning more to using that type of a construct even in trauma because of its improved characteristics in terms of stability, the reality is with other partners, they may not have the time to learn how to do a different technique. So I think being comfortable with both is important, and understanding the general mechanics of how these devices work is important to keep both yourself out of trouble and educate also your colleagues so that they can also provide the most beneficial fixation for their patients too. Okay, so this is an example of that. This is a patient who had a severe pilon fracture, and he was treated on call. The picture in the center is how he arrived in my office, and you can see that his tibia is angulated about 30 degrees. So we took off his splintus to see what the soft tissues looked like. He was an open fracture, and so that just kind of shows that that type of a construct with a delta frame, even though it was put on in typical fashion, has not stabilized the fracture. Some of the principles that led to that are the fact that the stability of a frame is dictated to some degree by the spread of the pins in this case. So you have the two proximal half pins in the tibia, but they're far from the fracture site. So if you want to have more stability, you have to spread those pins further apart. And the industry kind of makes these clamps which have a fixed spread to them. So if you kind of use that as your tool for applying the frame, if you don't pay attention to the individual injury that you're treating, you may have a situation like this. So putting another pin maybe more distal would have provided more stability to this frame construct. But inherently, the Delta frame, even though it generally works well, doesn't provide as much stability as a circular frame.
I think that that image is fantastic, and for everyone that is going to be able to listen to this podcast and not going to be able to see the pictures. I think that the one of the things that is happening right now that surgeons that they feel finally more comfortable with circular fixators, they're temporizing the extremity instead of a pin to bar system with just a very simple 2 half rings or 1 half ring around the proximal tibia and a half ring around the heel, and connecting those with threaded rods that still give you a lot of window for soft tissue management and provide more stability. Because in that picture, something obviously that is happening is that now you have an anticurvatum of the tibia with medial deviation of the distal segment, and that creates additional traction and soft tissue injury direct to the anterior angiosome that is already affected on a pylon fracture. So it's like a further damage to the soft tissue envelope instead of just stabilize not just the bone segment, but also further damage to the anterior angiosome that is severely compromised in these high energy fractures. So what in other words, what Tudor is saying is that because there's better options right now. One of the biggest factor is the learning and the ability to create that the surgeons need to have to transition from a pin to bar to a circular fixator, even in the acute setting. And also I know very well Dr. Tudor's capability, because he as an orthopedic also does neuromicrosurgery and he also does plastics. So he sees these injury in a not just in an osseous as an osseous problem, but also as a neurological and soft tissue problem. And but also we understand that it's really hard in the acute setting have the circular fixator trace there, get the wires. It's a lot more cumbersome. So these are the challenges that the surgeons have to deal with in the acute setting. You may be dealing with the OR staff group that is not capable or learning what is really needed for a circular fixator or knows all the components. For the most part, when you apply in circular fixator, the company vendors are present in surgery. They're not going to be available in the middle of the night or early sometime at night that to help us out with circular fixation. And it becomes more difficult just to apply itself because you need more hands in the OR to apply a circular fixator compared to a pin to bar external fixator. And I can see, Dr. Tudor, you can proceed with the picture that now we're seeing a circular fixator on a leg.
Yeah, well, so this is kind of the construct which I prefer in a lot of cases, just because it does give a little bit more stability. I mean, generally, in terms of getting a construct which is more stable, you need to have fixation near and far on each bone segment that you're trying to control. You want to decrease the distance between either the rod or the ring and the bone. So you want to have your fixation as close on the pins as possible. Increasing the number of connecting rods also increases the strength of a construct. Using if you're using half pins, the bigger diameter of the half pin is going to be helpful. You have to be cognizant. You don't want to use a half pin that's too big for a bone. So generally, I think the principle is no bigger than 1/3 the diameter of the bone. So that's why in that previous picture that we had of the delta frame, the half pin in the metatarsal is smaller than the half pins used in the tibia. So you don't want a fracture of one of your bone segments. Then doing multiplanar fixation increases your rigidity also. So in the pictures that we're looking at here, there is a half ring around the tibia. It is pretty close to the skin. Generally, you want to keep it about 2 finger breadths away, but in the middle of the night, you don't necessarily have all, the time to figure out all the rings. I generally have the OR make up some, I call them fusion frames, just so they're already pre-made and wrapped so that they're available for me to use. Some other companies do provide trauma circular fixators, and Orthofix does a good job of that, but it's not always available at all institutions. And then in this construct, we have a reference wire in the tibia, and then 2 half pins. We have 2 rings, and then in the foot we have thin wires in the calcaneus and thin wires in the metatarsals, and that just provides multi levels of fixation. You can see the soft tissues are easily accessible. Another advantage to this type of a construct, you can make sure that there are no problems. All the pin sites are healthy. You try to avoid putting the wires through soft tissues, which can be irritated by motion. And when you're putting in wires, one of the key principles is not to cause damage. So thermal necrosis is a big issue. So cooling the wires when you're putting them in with, I usually use normal saline soaked gauze is important. And then I usually tap the wire through the opposite side of the soft tissues once I got through the bone. Try to put all your wires and half pins in a fashion which minimizes trauma to the bone too. Half pins bicortical, and then the thin wires, you try to avoid putting it just through cortex 2, because that drilling through that causes a lot of heat production. And this is a good kind of stable construct for managing a pilon fracture until you can get to doing the definitive fixation.
Tudor, I see for everyone back again that are not gonna be able to see the picture, if I will also describe it that is that the 2 half pins in the proximal tibial block, they're slightly angled. That's something that I think that we should start adopting more and more for everyone is gonna be listening to this podcast. Instead of being perpendicular to the bone segment, they're slightly angled 5 to 10 degrees. There's more bone purchase, more stable. And also that in this frame construct, your half pins are protected within the tibial block. In other words, they're not above in an area that then rotation of the extremity can create a tibial fracture. We have seen it very well presented in the literature that when you have half pins that are above the fixator, they're more prone to create stress riser that could lead to full fractures of the tibia. So that's something that the picture shows very well. Then the other thing is the wire concept of 1 wire in the top, 1 wire below, so there's no deformation of the ring. That's something that we should always aim and that you were able to, like you so well said, space very well the wires from each other. In other words, your hind foot wire and your forefoot wire. And the forefoot wire seems to be always a problem because if the foot is not really at 90 degree, you are basically gonna try to really force the foot to be at 90, but you already have stabilized your tibial wires, and it becomes a problem to obtain a 90-degree ankle joint, and perhaps create some problems on the anterior ankle with compression of that area. And that wire that goes through the midfoot is very important that in some way when you applying for one in the other is try to mobilize the abductor hallucis muscle belly slightly inferior, so when you place the wire it doesn't create direct damage to the abductor hallucis muscle belly, because then it becomes more painful. Then the wire in the proximal tibia, the angle is just perfect. And his reference wire is an angle reference wire. It's not a parallel wire to the joint. It's a reference wire that is probably, if we go by anatomical axis, maybe about like 30 to 40-degree angle to the tibial crest, or it could also be measured by your longitudinal axis of the tibia. And basically what that does is more stability with the half pin that he plays from the medial face. And that's another great concept. Try to always put your half pins in the medial face of the tibia, but also be careful because there's not that much soft tissue envelope in that area. So if that area has been traumatized on with the in the initial trauma, perhaps not placing them in that area or avoid. And when you place them, be sure that when you insert the wire, it's really not a power half-pin insertion. Maybe just the near cortex is use power, and then use the hand component to advance to be bicortical, because we don't want to create further damage in the acute setting. But this frame, I think that Tudor's idea of having these fabricated frames in the sterile in the OR is it should be a more common practice among lower extremity surgeons. I would have to say I just don't know any other foot and ankle orthopedic surgeons that are doing this. I think Dr. Tudor and Dr. Vivo, perhaps that they do circular fixators also in the acute setting for periarticular fracture as a temporized device before either they transition to internal fixation, or perhaps in some cases just finalize treatment that way. And I think maybe what I could add that in this particular case, the circular fixator will have an additional advantage over pin to bar, that not just stability, but you could in this pylon fracture, in particular fracture, do some slight ankle arthrodiastasis that is linear, because usually with the pin to bar, when you do the arthrodiastasis, sadly the foot goes into a more equinus position. When you do arthrodiastasis with a circular fixator, is linear, maintaining the talus or the lateral process of the talus that is in direct line with the mechanical axis of the tibia or the anterior border of the fibula. And in those ways, it's a fantastic way to do the arthrodiastasis. And actually, I want to ask Tudor, in this particular case, you have the additional rockers or support to the foot plate or the foot support. In this particular patient, what is your weight bearing protocol?
I generally try to have people remain non-weight bearing, but I think having the rocker on is advantageous anyhow in a lot of cases, just because it allows people to set their foot on the ground, even if they're not weight bearing. I think it's just a lot easier for people to not have to hold their leg up in the air. And I try to be thoughtful about the fact that sometimes people are going to bear some weight anyhow. I think there have been lots of studies that have shown that even if you tell patients to be non-weight bearing, they may not necessarily adhere to that.
Yeah, we know that. Mm-hmm.
So, and that brings up another thought. In some of these cases, where we are doing our surgical intervention, there are two aspects of things. One is the technical aspect of what you're doing, and the other is the patient. And on the technical aspect, you want to create things which are stable, stable construct that's going to work well. But on the patient side of things, we kind of talked about having patients be participating in their care. That's very important, and having their cooperation. So when Dr. Rodriguez was talking about being careful where you put the pins in the foot and getting pain and irritation because a wire is misplaced, I think that's super important, because if you put on one of these frames and, as he said before, the patient is always asking you to take the frame off, it just makes for a very challenging post-operative course. So I think many people who do these frames really understand the importance of taking the time to put all the wires in optimally, because it's going to save you a lot of grief if you don't have pin tract infections, if you don't have wire breakage and other pain issues, which just make it difficult for you to accomplish what your plan was. In another aspect of that idea about the patient is understanding who your patient is. A lot of times for me, with patients who have ankle fractures, earlier in my career, there was, both by myself and I think others in the community, a tendency to not appreciate, for instance, somebody who has diabetes and neuropathy, who has an ankle fracture, how different that is than somebody who is a 20-year-old who has an ankle fracture. They're very different injuries, and they have different clinical courses. And so in this type of situation with those two types of patients, if you're going to say treat somebody with a frame, generally I find that diabetics don't do as well with half pins. They have more pin tract infections. They can break their tibia through where the pin is placed if it's not put in perfectly. Thin wires, I find, are much more forgiving. And that's just kind of an example of that understanding of your patient when you're making your construct and thinking about the fact that you might have to do something differently for different patients, and put that into your algorithm when you're deciding how to manage somebody.
So, Dr. Tien, you mentioned about the pin site infections. What is your protocol when you see your patient in the office and you think that there's an infection brewing? Like, what is your protocol, and do you have any go-to treatment methods?
Great question. I would say I try to remember to tell the patients in the reconstructive use of a frame that pin tract infections, wire breakage is just something that they should anticipate, and that we may go back to the OR to do changing of a pin or removing a pin and putting a different pin in, just as part of unscheduled but ongoing management of the frame. So if I see somebody in the office who has a pin tract infection, my first question is, okay, is there instability in the frame that I need to be concerned about, and kind of assess that and try to figure out that aspect of things. If it's simply that there's irritation because there's soft tissue pistoning on the wire, or that the patient hasn't had adequate pin care, then I might focus on that. generally, I use normal saline and half hydroperoxide mixture. I'm okay using just normal saline also. Some people use Hibiclens, which I think is fine too. And I generally focus on trying to put gauze padding around the pin and have it placed so that it minimizes soft tissue pistoning on a pin. I always kind of tap the thin wires with some type of object to make sure that they have the right kind of tonal ping to them and feel, to make sure that they're not getting loose in the bone. And I always check the x-rays to make sure we're not losing fixation. And that's the reason why we're having pin track problems. I kind of use the external fixator sometimes in kind of super duper construct where I do internal fixation on a diabetic neuropathic ankle fracture, then I put external fixation on the outside. And I kind of use the external fixator in that situation as a warning device. If I start having a lot of pin track problems, it just alerts me to the fact that the patient is not able to maintain a non-weight bearing status and they're, having problems. And certainly when you have obese patients who are, 350 pounds, with a, super high BMI, it's really hard for those people to stay non-weight bearing. And you just have to be aware of that. I have a low threshold for just going back to the OR and doing a wire exchange. So I don't mind putting people on a short course of oral antibiotics if they have irritation around their pin sites, but I'm usually doing that as a temporizing measure with the idea that it's probably not going to be successful and I may have to either change the wire or do something else. So that's generally the way I look at those when I'm in clinic.
Got it.
You know
Great.
what, Lauren, if I can add, so
Sure.
with Dr. Tudor, I think that there's a few points that are very important. In the acute setting, the pin side, well, let's look into it was stabilized with the pin tubar in the acute setting traumatic event. The infection that you may see is because that local area where the insertion of the happy was placed, there's some thermal necrosis at the time of the insertion, or that skin paddle was in the process of being compromised avascular that leads to the infection. So avascular areas of the skin paddle are going to be more prone to be infected, and that's the reason perhaps that we need to always insert the half pins away from the zone of injury because they're going to be always more prone to get infected. Plus, the insertion will create also further damage and inevitable damage to that area. So that's number one on the pin to bar. In the complex reconstruction that he's mentioning as using the fixator over internal fixation for the charcot joint, dislocated ankle, neuropathic patients, obese patients, it's extremely hard because you had to use a very big, large size ring around the extremity, but the bone segment is so far away from the inside of the ring that no matter if you tension at 130, there's gonna be significant deflection of the wire in the AP and medial lateral alignments and stability. So the use of half pins to add on is significantly beneficial in those cases for adding additional stability under the wire placement. But inevitable, like he so well said, these patients are not going to be fully non-weight bearing. And the minute that the patients stand up, if they're over 300, that wire that was tension at 130 may go significantly higher in tension, and that's when they're more prone to break. That's something to really think about it. The other factor is when you take the x-rays and you see that the wire, if we talk about transosseous wires only, you see a slight cavitation or radiolucency in the bone. that wire already lost the wire bone segment stability. And that wire, by definition, is what he said is going to start pistoning in the AP or medial lateral. And then in that way, you have to remove that wire because you compromise. You already stability in that segment will be compromised because you need minimum 2 point of fixation per ring segment. So that's very important to take X-ray just to see if that wire at the bone interface is being compromised already. If it's superficial, irritation or redness around the pin, we can go by the Cerner Mader classification of like 1 centimeter. If it's 1 centimeter redness, usually it's something more localized to that area. Maybe the wire lost some tension, but at the bone segment is still stable. So basically, just retension the wire. We ask the patient to stand up or just manipulate the wire after it had been retention. And if the wire is not painful, then just treat that locally. But the treatment was really retention that wire. If you tension the wire and the bone segment you see in the radiolucency on the radiograph, then that means that no matter if you tension the wire, it's going to be unstable at the bone segment. That wire had to be removed. And usually it comes with additional redness in the circumference of the wire because there's more motion. So you may see like a patch of redness that is more painful, maybe some increased heat in that area. And those are the patients that could possibly end up that you need for sure, not just local site care, but also PO antibiotics, like he said, that a short course of antibiotics will be also beneficial. But understanding that if the bone segment had been compromised, that wire has to be removed completely. And also, lastly, expect that to happen on patients with diabetes. We know that their ability to fight infections are is really poor. And when it comes to cleaning, and I think that every single surgeon that I talk to has some cocktail of how to treat pin site infection. And I think that that's when we can just probably talk a little bit further here. Is that Dr. Tudors, he said he used some saline, some peroxide. Some surgeons are using Hibipin, and I've been there. We have used that, and I think it's what we have in our clinic. But still the most important thing is what he just said. Check for stability right away of that wire. If that wire is stable in the skin or is unstable at the bone segment. And then from that point on, you start your algorithm of how to treat that pin site, which I do the same. I tell the patient if the wire gets red and hot, we have to work on it. And it's just part of the treatment. I don't see as a complication because I'm not changing the plan. It's just a little bump in the road, I say. And I think that that's really a key the key points. Dr. Tudor, what is your antibiotic selection when it comes to these cases and in the high risk and the non-high risk patient?
Antibiotic selection? You mean for pin tract infections?
Yeah, did you culture? I know that some surgeons, they say that they try to culture deep and then based on that, what is your approach?
Great question. I think sometimes I culture it. I don't always culture it. If I choose one antibiotic to use, I often use Keflex as a temporizing antibiotic for a week. If I'm concerned it might be MRSA, I might use doxy, cycling. So those are the probably most common antibiotics I use in those settings. Occasionally I might use something different, but I would say generally those two.
Yeah, I found myself using similar antibiotics, the cephalosporins and the doxycycline, and even sometimes if I see that I feel like there may be some bone involvement, I may either use Bactrim for the sake of the bone penetration, just to be sure that I can maintain that area as free as possible of any bacteria. What about the when it comes to that will be the same on the high risk and the non risk patient? I mean, that would be the same scenario for you.
Say that one more time.
That's the same antibiotic protocol for the high risk and the healthy individual versus the healthy individual.
I would say most of the time, if I'm getting into any type of question of antibiotics, I defer to our infectious disease department. So in high-risk patients, they've probably already seen the infectious disease doctor, and I've talked to them, and they have some type of a planned regimen. Certainly, I have a number of patients where when I do these external fixators, I've already committed them to 6 weeks of IV antibiotics. And so in that type of a setting, it's been predetermined. And in the case of the healthy patient, kind of what you said exactly, those, Keflex or doxycycline or Bactrim would be, what I feel comfortable. When it starts getting into anything past that, I generally am not the one primarily involved in choosing the antibiotics. Because there's so many special ones out there that have such good characteristics, but I don't prescribe them often enough to feel comfortable doing that generally.
Tudor, in cases of like Charcot joints with internal fixation and augmented and protected with circular fixation, that obviously for the most part we encounter pin site infection. At the time that you take the fixator, do you keep them in antibiotic for some time, or you basically, if clinically everything looks reasonable, you don't continue antibiotics? Although we know that for the most part, this patient on fixator for a long time, the skin never looks within normal. Do you keep them in antibiotic protected for a while, or you just basically make that assessment on a case by case?
I would say I don't generally keep them on antibiotics after the frame comes off. I want to know whether things are good or not good, and I don't want to kind of like mask things and confuse myself. So I usually debride all of the pin tracks when I take out the pins. I haven't routinely put in any type of absorbable bone void filler mixed with antibiotics when I take out the pins, although with the advent of some of the newer pre-formulated antibiotics in absorbable bone void filler, I think using something like that at the pin sites isn't a bad idea at all. So I would say no to antibiotics after the frame comes off, but good debridement of all the pin sites when you take the frame off, and potentially thinking about putting in some type of local antibiotics mixed with bone void filler might be something reasonable.
Perfect. No, that's I agree. It's just a topic that is still, is it's just so hard for younger attendings and residents that if they're using circular fixator, how they can minimize the complications in the with pin site infection and problems. And I think that the best answer I can give, the better you put the frame, the less complications you're gonna have. And I think, Tudor, I don't know if you agree with that. The more time, the more careful you put the wires, the better your angle. The more careful is when you insert them that you don't create thermal necrosis. The better that you put the frame that is orthogonal to the leg. that you have the right distance between the zone of injuries and the wires, the less struggle is going to be in the clinic. And instead of being a perhaps 20-minute visit, which will be great, you can avoid these 45-minute visits when they come in, that it really puts completely on hold your entire clinic day, and it disrupts completely your quality of the evolution of your clinic.
Yeah, I think those are all good points, and I think that you really have to have that kind of global uh, thought process about these things. I think if you don't know how to use these type of things well, because you haven't had a lot of experience in your uh, training as a resident, or perhaps even in your training as a fellow, you have to sit down and kind of apply that concept of lifelong learning, uh, and make a program for yourself to familiarize yourself with this type of device and how to use it, and go to enough courses so you kind of get a flavor for what you should be doing. And then I think the next step is choosing things which are simple. So if you're doing trauma, putting on a delta frame is fairly straightforward. I think for the most part, you ought to be able to do that type of work without getting into trouble. And then kind of get a feel for that, how it runs through clinic. Those only need to stay on for a short period of time, 3 weeks, uh, you know, some somewhere in that neighborhood. So it gives you you're not committed to some huge thing. Your staff can handle it. You should be able to handle it. Then, if you want to do some type of reconstructive things, you have to figure out, okay, how am I going to approach this? And if you want to choose something which is fairly straightforward and simple, an ankle fusion frame is a great device, generally very forgiving. Um, and you can start with that, and um, you ought not to run into a lot of problems using that type of device. And after you do a few ankle fusions, then you can start to expand and consider doing other types of uh, bony corrections and a whole host of other things that you can use the frames for. But I think all of us have to kind of keep that in mind, and as we adopt new techniques, to make sure that we build ourselves uh, a learning program where we and our patients benefit and we avoid trouble.
Yeah,
Oh,
I think that those are great summaries, and I know that everything sounds like straightforward, but sometimes we just don't practice what is straightforward. But we do know that for circular fixation, we have to practice a little bit more.
Dr. Rodriguez and Dr. Tien, can you talk about potentially using like a non-antibiotic infection prevention polymer such as Preventagen? Dr. Rodriguez, I know you've used this in Mexico, so this is something that maybe can be used instead of like the normal saline potentially. What I like about it is that it contains no antibiotics, but it's resistant against bacteria, and or it breeds bacterial infection, and it can protect against fungal infections as well. So what's your experience on Preventagen?
Well, I think that so my experience so far has been on the cases that have been done in my practice in Mexico, and it has been extremely beneficial. I think other products that I have used in the past, like silver dressing, I think that I have used the silver dressing. I have used also the ones from multiple companies that is basically a Hibiclin type of patch, also used in the hospitals for like central lines and IV access protection, and it works also well. But I think that what we all know is like, okay, what is the easiest thing that we can do that perhaps the patient can do and less expensive. And I think that's to be determined. That those products right now are not that available to everyone. I know that the product that Preventogen is a fairly new product. My experience has been with the inpatient with the traumatic patients, not the patient with charcoal joints, which the patient with charcoal joints, they're always going to be more prone with
Right.
soft tissue infections. So I think I can only speak that from the traumatic type of event and the type of trauma in the healthy individual, but with a difficult or or significant injury. I have been extremely happy on preventing soft tissue infection. But also keep in mind, I'm very technical how I put the fixators. I definitely don't want to breach any instability aspect of how to put a fixator. And yeah, if when we see that there's instability in the frame, no matter what product you use, you're gonna have some colonization of that area, and then that will lead to additional problems that we know. So first thing first, stability and adequate placement of the device is mandatory before, like we mentioned, to prevent any or decrease the likelihood that these soft tissue infections can happen after. I don't know, Tudor, do you have any experience with silver dressings?
Yeah, I've used those, and I think all the points that you said are right on. I think the product sounds very intriguing to me. From my uh, review of the literature, it seems like it would definitely be advantage to have that. I think in terms of the problems that you were touching on, and I had mentioned before also, if the wires are loose, this product isn't going to help. If there's thermal necrosis when you put the wire in, this product probably isn't going to be beneficial either. And so the basic technical things that you need to pay attention to when you're putting the wires are going to be important whether or not this product is used. So I think the benefit of the product is keeping uh, any bacteria that's there, uh, killing it, and then preventing any contamination locally. So I think uh, that's the benefit, and I look forward to if I have the opportunity to use it to use it, and hopefully I'll have a good experience like you have had so far.
Julie, maybe Julie can mention a few things from a product standpoint. Each is with
Yes.
this morning. She can mention. I mean, how the surgeons can perhaps get some samples. How get some literature. Is always a concern. It's always I get calls all the time. What is your recent pinside care protocol? You'd be surprised. It's a question that we get all the time in our service. Like, what is your recent cocktail of how you cleaning? And sometimes I will have to say, sometimes not doing that much cleaning. In other words, don't letting the patient do it is a factor also, especially in the patient high risk. If you let them do it, they create more problems. So if it's a patient that is a healthy individual, perhaps they can do their own pinside care. But if it's a patient that is high risk with a poor soft tissue envelope, maybe you want to do those in the clinic, and then that's when maybe perhaps this product may be also very beneficial.
Absolutely. I mean, we are, like I said, we're kind of trailblazing through here. We're trying to find where the best area to use this product was, and we're so grateful to have thought leaders like yourselves try it out. I think what makes it so special is the fact that to date, there's nothing that we're resistant to, and that it is a microbicidal product. So, like I said, we have lots of testing that shows that it kills bacteria, fungus, and viruses, pretty much anything on contact it kills. But I think what makes it unique in this setting is that that Dr. Rodriguez and I have talked about is that it's a quick, and you mentioned several times during this podcast the importance of this being a simple process that can be utilized easily, quickly during clinic, and it brings maybe your clinic visits down to 20 minutes versus 45. We've the product itself comes in like a liquid, and I'll be sure once you squeeze it, you just put it right around the pin, and it's a liquid, and right away the first thing it does is that it kills, and it'll kill any kind of microbe it comes in contact with, being bacteria, fungus, or whatever. But within 30 seconds, the product actually turns into a film. So that's what I think makes it so unique, is that it's killing and then turning into that film and protecting that area really fast. So I think that helps just to decolonize that area and keep it nice and clean during the process. But it is easy to get. We'll make sure if you go directly to our website, there's a link to anybody that's interested in trialing it. We love having information and data on it. The more we know, the better we can serve you all. So we want to be a part of this path to making external fixation easier.
Up here, I just want to thank everybody who participated. Thank you so much, Dr. Tien, Julie, Dr. Patel, and Dr. Rodriguez for participating today, and for everyone to check out the podcast on iompodcast.buzzsprout.com, or you can go on Spotify and Apple Podcasts as well, and also look for supplementary information on the Instagram page and as well as YouTube.